HLA genotyping of the patients. And in the patients who positive of the biomarkers, as they are the carriers of either HLA-B1502 or HLA-A3101 in the heterozygous or homozygous, this patient can define as a high risk of the scar from the carbamazepine. Therefore, the carbamazepine should be avoided for prescriptions in these patients. And on the other hand, in the patients who are non-carriers of the biomarkers, of the both biomarkers, the carbamazepine can be prescribed in that patients. So, however, as Professor Lee mentioned about the ethnic specificity, so when you look into the frequency of the HLA-B 1502, it is predominant in Southeast Asian population and also in Han Chinese. However, in some country, in some populations, such as in Americans, Europeans, Africans, and also Koreans and Japanese, the HLA-B 1502 look like nearly zero frequency in that populations. So therefore, in the European country, Americans, Africans, and Koreans and Japanese, they has another biomarker that not HLA-B 1502, but it is HLA-A3101. And so this is we call ethnic specificity. So therefore, when you would like to order the pharmacogenetic screening, so you should consider about the ethnics of the patients as well. And so moreover, in our case study, we found that even like we screen for the HLA-B 1502, which is a biomarker in our Thai populations, but we also that these patients who screen for the HLA-B 1502 and the results show the negative of the biomarkers, and the physician prescribed for carbamazepine for these patients, and this patient came back to the hospital with the Stevens-Johnson syndrome. So when we did the genotyping of the HLA-B in these patients, and we found that he is the carriers of the HLA-B 1521. What is the matter of the HLA-B 1521? So HLA-B 1521 is in the same family of the HLA-B 1502, which is we call serotype 75, that composed with the another alleles such as HLA-B 1508, 1511, and 1521. So therefore, in the patients who are negative of the HLA-B 1502, but they are carriers of the another serotype 75, the carbamazepine should be avoided in these patients. So not just only in the Thai populations that we can confirm the association with the serotype 75, but you can see in the Indonesian populations, Filipinos, and also in Japanese, they also show the associations of the HLA-B serotype 75 for the carbamazepine-induced Stevens-Johnson syndrome and TENs. And so when you do the screening of the HLA-B 1502, and in the patients who are positive of the biomarkers, which is HLA-B 1502, even heterozygous or homozygous, the alternative choice can be another aromatic anticonvulsants, except for oxcarbamazepines, because oxcarbamazepine is very close structure with the carbamazepines, and it can be metabolized to be the carbamazepine structures in the patient's body. So these guys got the positive of the HLA-B 1502, and the physicians choose oxcarbamazepine as an alternative choice, and he came back to the hospital with the Stevens-Johnson syndromes. So therefore, the oxcarbamazepine is not a good choice for the patients who are positive of the HLA-B 1502. And moreover, as Professor Lee mentioned about the phenotype specificity for a biomarker of carbamazepine, the HLA-B 1502 shows strong association with just only for SJS and TEN, but it is not for DRESS and MPE. So however, for the HLA-A3101, they show the strong association with the SJS, TEN, DRESS, and also MPE from the carbamazepine. So in this case, we got the sample from the patients who got the DRESS syndrome from carbamazepine, and doctor would like to use the pharmacogenetics biomarker to identify the culprit drugs for the patients to stop the right drug and continue with the other drugs to control the epilepsy patients, epilepsy conditions. So therefore, in this case, we recommend to genotype for the HLA-A3101 because we know that even the HLA-B1502 has been genotyped, but they are not show associations and they are negative in this case. And you may see that in this case, we confirm that the HLA-A3101 show the association with the spectrum of the scar in the carbamazepines, as shown you in this report. And so by summary, for the practical point of the carbamazepine screening, the HLA-B1502 is strong associated with carbamazepine and oxcarbamazepine induced HAS and TN. They share risk marker between carbamazepine and oxcarbamazepine. They have the phenotype specificity and also ethnic specificity. So in the clinical implementations, when you would like to order the biomarker of the carbamazepine, the ethnic specificity of the ethnic of the patient should be considered for the order. And also they have another risk and reals that should be considered, not just only HLA-B1502 in Asian populations, especially in Southeast Asia, such as 1502, 1508, 1511, and 1521. This is a practical part for the carbamazepine screening. So let we move to the next biomarker for the allopurinol screening. For the allopuriноls, nowadays, the HLA-B5801 has been accepted to be the biomarker for the allopurinols. And for the genotype of the HLA-B5801, we can stratify the patients into two groups. The first group is the patients who are positive, who are the carriers of the HLA-B5801, even heterozygous or homozygous. The allopurinol should be avoided in these patients. And on the other hand, in the patients who are negative of the biomarker, the patient can be prescribed for the allopurinols. In the patients who are positive of the HLA-B5801, the alternative choice can be febuxostat or probenecid. However, for the febuxostat, the physician should be considered for the another adverse drug reaction from the febuxostat, which is a cardiovascular adverse events. And not just only for the genetics marker of the allopurinols, but allopurinol has another predisposition factor, which is a non-genetic factor, such as the gender and renal status of the patients and elderly patients, and also concomitant drugs, and also the dose of the allopurinols. So therefore, in 2020, American College of Rheumatology recommend to start the allopurinol with the lower dose, less than 100 milligrams, because in the patients who treated with more than 200 milligrams, they have a high risk of the severe cutaneous adverse drug reaction from the allopurinol for 30 times of the patients. And also American Rheumatology recommend to screen the HLA-B5801 before prescriptions of the allopurinol in Southeast Asian populations, including with Chinese, Korean, and Thai, and also African American patients as well. So in this case, so I would like to show you that the family history of the patients and the allopurinol-induced scar is a genetic factor and also non-genetic factor, because in this patient, she got the allopurinol for 1 year for hyperuricemia treatment. And after 1 year, she got the allopurinol-induced toxic epidermal necrolysis. After physician increased dose of the allopurinol from half dose, 150 milligrams a day, to 300 milligrams a day. And also during that times, the renal impairment status of the patients has been renal impairment status as well. So therefore, she got the allopurinol-induced toxic epidermal necrolysis. So after that, the physicians request to test the HLA-B5801 and the HLA-B genotype of the patients shown you here, that she is a carrier of HLA-B5801. And so after she died from allopurinols, we got the information from the family that her mother also died from allopurinols-induced scar. And in her family, one of her sons treated with the allopurinol, but without scar. And when we did the genotyping for this boy, this patient, this man, we found that he is non-carrier of the HLA-B5801. So therefore, it's luckily for him that he is the non-carriers and can be treated with the allopurinol without scar. Even his mom died from allopurinol. And so by the practical point of the allopurinol, they are ethnic non-specificity because the HLA-B5801 distribute throughout the populations worldwide. So, and there are phenotype specificity because in our study, we shown that HLA-B5801 shows strong association with SJS, TEN, DRESS, and also MPE. And they have those related with risk of allopurinol-induced scar in the setting that you if you cannot access to the HLA-B5801 genotyping, and so you should be able to treat the allopurinol with the lower dose, less than 200 milligrams, or sometime if you're waiting for the result that return from the pharmacogenetic screening, the dose of the allopurinol should be prescribed with the lower 100 milligrams a day. And also in the patients who have the underlying factors such as the renal impairment, this patient has a very high risk of the allopurinol-induced scar. So therefore, we strongly recommend to do the screening in the patients who has the renal impairment status. And also, if you choose the febusostat as an alternative choice for the HLA-B5801 positive patients, the cardiovascular adverse event should be monitored in that patients. And lastly, the biomarker for the abacavir-induced drug hypersensitivity is the HLA-B5701. And when the physicians would like to prescribe abacavir, the HLA-B5701 should be genotyped. And in the patient who are positive, even heterozygous or homozygous, the abacavir should be avoided for these patients as well. And so right now, so you can see that the role of the pharmacogenetic testing in the drug allergy can be test before prescriptions to prevent the scar. And for if you would like to test before prescriptions, all naive drug individual should be tested. And in some time, the patient who treated within 3 months should be considered for the screening as well. And however, after 3 months, if the patients already prescribed for drugs, there are no need to screen for the patients who are treated longer times. And also, sometimes the pharmacogenetic testing can be tested after the patient got scars to identify the culprit drugs. So for the positive biomarker can be confirmed the drugs. However, on the negative result cannot be ruled out such drugs in the scar patients. And so now today, all of the biomarker that I already mentioned has been implemented in the many countries, including with the high income country and also in the middle income country, in Asians, not just only in Taiwan, but in Singapore and in Thailand, we also implement the pharmacogenetic screening as a national policy screening. So in Thailand, we implement the HLA-B5801 for the carbamazepine and HLA-B1502 for carbamazepine and HLA-B5801 for allopurinol. In our country, the patient no need to pay at all because all of the tests, the government support 100% cost for the patients. And right now, we also discover the potential novel biomarker for cotrimoxazole and also dapsone, which is HLA-B1301. And we are now trying to put our effort to implement as a national policy screening in our country. And hopefully that can be usefulness in other country, in other populations as well. And so usually in the clinical setting, the pharmacogenetic screening has been provided as a specific biomarker testing So for example, in this case, the patients going to treated with the carbamazepine and the doctor order for HLA-B 1502 and the results show that positive or negative. And however, in our country, we not just provide for the specific biomarker screening, but we also provide the HLA-B genotyping testing. And they are very useful for the patients who have a secondary finding. And also, it can be prevent the patient who negative for HLA-B 1502, but they are the carrier of serotype 75 for carbamazepine treatment patients. And so this is an example that what is useful for the HLA-B genotype testing. So in this patient, he got the early sign of Rett syndrome. And so in his regimen, he got Bactrim and also allopurinol. And at that time, physicians suspect that he got dressed from the allopurinol. So therefore, he ordered allopurinol screening test. And however, in this case, he got the negative of the biomarkers. However, when you look into the genotyping, you can see that he is a carrier of HLA-B 1301. So therefore, in this case, we can use the HLA-B genotyping that point for a Bactrim as a culprit drugs. So therefore, we can stop the Bactrim and let the patients discover from the Rett syndromes. So this is a benefit from the HLA-B genotyping. And my last case, I would like to show you not just only for the pharmacogenetic testing that should be considered, but also the knowledge of the physicians and also the electronic medical record and also counseling should be implemented and should be set up in the clinical setting. So in this patient, she got the HLA-B 1502 positive result. Therefore, the physicians avoid to prescribe carbamazepine for her during she was admitted in the hospital. However, after that, she discharged from the hospital with the phenytoin, and the doctor requests her come back to the hospital 1 month later. And so she came to the hospital and see another doctor, and that doctor considered carbamazepine for her. And so the doctor prescribed carbamazepine for her because in the electronic medical record, there has no pop-up or there has no alert system. So therefore, she got carbamazepine-induced toxic epidermal necrolysis. Therefore, we encourage to do the electronic medical record set up to alert the doctor when prescribed high-risk drugs, including with abacavir, allopurinol, and also carbamazepine. And the electronic medical record can block for the prescriptions if the patient is a positive of the biomarkers. And also the counseling is very important because in electronic medical record, it is not connected between each hospital and also in the pharmacy. So therefore, we believe that if we can let the physician, if we can let the patient know their own risk of the drugs, they can prevent themselves. And during the counseling, we can do as a personal or telecounseling. And for the counseling system, counseling process, we provide them the pharmacogenetic card to let them know what their own risk drugs and that should be avoided in the future. And so this is the impact of the pharmacogenetic screening in our country. You may see that the number of the pharmacogenetic screening has been increased for every year. And on the other hand, the number of the Stevens-Johnson syndrome and TEN has been decreased year by year. And by the take-home message, before I close my sessions, so the pharmacogenetic test can be considered as before treatments for prevention and also after scar events for the culprit drugs. And for the biomarker in the clinical practices, the HLA-A3101 for carbamazepine in Europeans, in Koreans and Japanese populations. But for in Southeast Asian populations, the HLA-B 1502 and also other serotype 75 should be considered for carbamazepines. And HLA-B 5801 this is a biomarker for allogeneic HLA-B5701 for the abacavir. And we also have the new biomarker for cotamoxazole and dapsone, which is the HLA-B1301. And the electronic medical record for other system and CDSS system is a very important tool for the clinical implementations, as same as for the pharmacogenetic counseling to give an informed consent and also provide the pharmacogenetics or the genetic profile for the patients. This is very important for the clinical implementations. And so last slide, I would like to thank you all of my collaborations for our research and also clinical implementations. And thank you very much for your attention.
Thank you very much, Professor Sukasan, for the excellent talk. I'm sure the audience tonight agree with me. We have 3 excellent speakers presenting on 3 different topics or subtopics that's full of insights. I'm sure the audience tonight have learned a lot from the speakers today. I'm seeing online there are quite a few questions from the audience. Let's just go through the first one. The first question is, which specialists are usually consulted to help diagnose culprits of scar? Do dermatologists perform in vitro tests or drug allergy skin testing or challenges? What is the role of allergists versus dermatologists in diagnosis, management of scar in your country? How about we get Professor Lee to answer this question, please? Yeah.
So I think, the initial presentation of SGST and sometimes can be very non-specific, right? It could be just prodromal symptoms and exanthum. So I think with that initial presentation, they can end up in various specialty, whether you're a family practice, emergency physician, allergist, or dermatologist. But I think as your skin worsen and you get widespread detachment, I think most of them do get transferred on to the dermatological ward of the burn center just because of the demands of wound care and managing all of those complications. With regards to the question on allergy testing and in vitro testing, so I think in vitro testing, it's not readily available, and the sort of pickup rate is not very high, or it's not as high as what we wished it to be. Likewise, for patch testing, it really varies depending on what the reaction is and what drug are you suspecting. So generally, I think in terms of drug causality, we like to just, think about in terms of the drug notoriety as well as the latency, which is the period from initiation to the onset. And there is an algorithm known as the Eldon score, which has been used to sort of help clinicians to diagnose the culprit medication.
Yeah, I agree. I think many of these cases of scar, it kinds of overlap between allergy, immunology, and dermatology, and sometimes with infectious diseases as well. Okay. The next question is about, for allopurinol use in person with HLA-B 5801 positive, how many patients who really develop scars? How about we invite Dr. Tang to respond, please?
Yeah, I thought it's our yes questions. Yeah, actually it's quite low. What do you think? How you? Yeah.
Yeah, so I think it probably varies depending on your baseline allele frequency. But in Singapore, and I'm sure also in Thailand, our positive predictive value is about 2%. I'm not sure whether that is what it is in Thailand as well. So I guess the majority will be fine, but SGSTN is such a severe disease, you really don't want to expose patients to such a risk.
Let me share for my side. So actually, it is very rare cases of the allopurinol induced scar even like they are positive of the HLA-B5801, for the predictive positive values in our population is about 2. So that is not very quite high. And so just only 2% of the patients who carry of the HLA-B5801 got the scar from allopurinol. And as I mentioned that not just only for the genetics that is a predisposition factor, but there are another factor which is non-genetics that might be involved with the immunoreactions, including with the dose or the level of the molecules, oxyallopurinol as well. In the patients who have a higher risk, not just only for the positive of the biomarker, but it's also renal impairment status and also high dose treatments. Yeah.
All right. On similar topic, for Professor Sukarsam, what is the criteria to offer genetic analysis, and what is the clinical implications of this genetic thing based on our experience in Thailand?
Yeah. Okay. So in our country, as I mentioned that the both biomarker HLA-B1502 and 5801 has been implemented as a national policy screening, because we do the cost effectiveness analysis and they show the positive for the screening. And in the criteria for HLA-B1502, all indications of carbamazepine treatment can be ordered, can be requested for the screening. But for the HLA-B5801, just only for the gout patients can be ordered for the HLA-B5801 screening. So however, they are not the mandatory for the clinical practices. But in some time, we got the challenge from the physicians that they don't want to screen for HLA-B5801. But we convinced them with our data that if you don't want to screen for all patients, but the subpopulations of the patients, such as the renal impairment status patients, CKD patients, you should screen because they have a high risk of the allopurinol, even they are not. We don't know the status of the genetic background of that patients. This is the information that we try to convince our physicians to do the screening. Yeah.
What might be the reason for refusal for screening?
Sorry?
What might be the reason for refusal for screening from patient's point of view?
Okay, so because they thought that sometimes they are how can I say, they are Islamic patients, and the patient don't want to know their own risk, because they thought that God, his God decide their life. They don't want to know what is a risk. If they die from the as God decide, they want to be. And in sometimes on the physician side, physician don't want to prescribe the alternative choice, because the alternative choice is very high cost. For allopurinol is just very low cost, but febuxostat is very high. So therefore they don't want to prescribe a high cost for their patients.
I see.
They want to save the patients from the costing. Yeah.
And just to clarify, the tests are done in-house in Thailand itself, in Bangkok itself. Is that right? Yeah, the tests.
Yeah, the test we provide as a HLA-B genotyping, as I mentioned.
Yeah. Okay. Thank you. We'll move on to the next question. Among genes involved in drug hypersensitivity, only several HLAs are strongly associated with scar. So we normally administer to screen for specific HLA for a specific drug. But some genomic companies promote gene panels to screen for risk of hypersensitivity against many types of drugs. Would you recommend that? I'll just open to the floor for all three of you to share your views on that.
So let me share my view first.
Yep.
So as I provide the HLA-B genotyping, so therefore by the informations. As we know that the HLA-B is a germline genes, so there has no change the whole life of the patients. So therefore, once in the lifetime to test that pharmacogenetic testing, and we can use that information to predict the drugs that associated with HLA-B genotyping for 7 drugs right now, according to our database. So therefore, in my experience, I found that some patients, the doctor requests for 2 tests because they would like to prescribe, for example, allopurinol and carbamazepine. If they test for a specific biomarker, they need to pay for 2 times, and they need to waiting for the result to return for their hospital. So therefore, if they test as a panels, they can use that information to prescribe the patients, to prescribe the drugs for the patients without lag times. And also they can use that genotype for the whole life of their patients. So I myself, if the test for the HLA-B genotype is not so high cost, I would recommend to do. So in my setting, for the specific biomarker testing is about $30 baht. But for the panels, we provide just only $60 baht. I'm sorry, US dollar. Yeah, $30 is yeah. That is not so high
for one panel.
Yeah.
One allele, is it?
For one biomarkers.
Mm-hmm.
Yeah, $30 for one biomarkers. But a panels just only $60.
Okay. What method do you use?
Okay, we use the Luminex PCR SSOP.
SSO. Okay, all right.
Yeah.
So Hao-Yue, what about you?
In Singapore, we don't do panels, so we often just use prescription. So I think, the pharmacogenomics and genetics is very established in Thailand. And I think part of the reason is because they have been able to determine, what's your baseline frequency and the, association between certain drugs and certain alleles have been validated. So I think you can use this sort of panels confidently. Whereas I think certainly in Singapore, we can't just, plug a allele that's reported in the literature and then, have our patients screen on it, because we don't know first what is the baseline allele frequency and whether there's such a true pharmacogenetic risk exists in our population. So I think if it does, then eventually I think it's worthwhile, because like what Professor Sukasen says, it's really a lot cheaper to be able to do one test, just once.
Yeah. Okay.
And another reasons that why we provide the HLA-B genotyping as a panels, as I mentioned that in the patients who carry with the serotype 75, we lost our patient from a specific biomarker because he carry HLA-B 1521 that got Stevens-Johnson syndrome, and we don't want to lose our patients again.
Okay, thank you. I think in the interest of time, we'll just move on to the remaining questions. There are quite a few of them waiting to be answered. The next question is, do you have pharmacogenetics tests for anti-tuberculosis medications?
Okay.
Yeah.
Yes.
Yeah. Anyone? Yeah.
I think Professor Sukasen.
Yeah.
I'm sure Thailand would have.
So if you talk about the anti-tuberculosis induced scar right now, we don't have the biomarker yet. But for the anti-tuberculosis induced liver toxicity, we provide the pharmacogenetic biomarker, which is the N-acetyl transferase enzymes genes to predict anti-tuberculosis induced liver toxicity in our populations. Yeah.
Professor Sukasen, in TB medications, they are often given 3 or 4 together. Then how do we determine that, the pharmacogenetic association is truly to one drug, because at least in Singapore, the ID physicians like to re-challenge or swap TB medications.
So we did not provide the screening for all patients who going to treated with the anti-tuberculosis, but we provide the testing if they got the liver toxicity. Yeah. If they are positive of the biomarker, we let the physicians know that which drug should be should be stopped in the combinations.
Thank you. The next question, in the emergency room, where there are no facilities for immunological tests, is there a place for skin tests before prescribing an IV medication such as antibiotics like quinolones? And how do you determine a positive test using skin tests in the ER?
In Singapore, I don't think we practice such thing, because I think often there is an urgency to the initiation of antibiotics, particularly if it's intravenous. I am not sure if Dr. Falk or Dr. Tang or Professor Sikapsen would have similar views on this.
No, I think usually for skin testing, when it comes to drug allergy, they're all booking in an outpatient setting, perform in the clinic if it's needed, or book a separate time rather than in the case of emergency performing the test in ED.
We don't do pre-prescribing testing, and as you know, if you want to have a positive result, the patient must be sensitized first. If your patient is not being sensitized before, and then you try to do a pre-prescribing testing, usually it will be negative. And of course, there are a lot of factors that affect the reactivity of a patient towards the antibiotic. Could be the infection itself. So it's not the idea, not the best time to do the test. When you want to give the patients antibiotic, when it's indicated, you just go ahead. Yeah.
Yes. And there's one last question from the audience. What is your recommendation for patients who are already on allopurinol in testing HLA-B5801 postemptively? In our public hospital settings, they suggest testing all patients prior to starting allopurinol and those that have already started on allopurinol within a year. Is the timing of being on allopurinol that important? Should we consider widespread postemptive HLA-B5801 screening for all patients already on allopurinol? Or should we consider other risk factors as Professor Sukasam suggested? For example, dose of allopurinol, concomitant diuretics of CKD, as well as checking HLA-B5801 if we are also taking cost into consideration.
Yeah, so I'm not sure that I can answer you are not, because the HLA-B5801 in our country, we strongly recommend to do the screening before prescriptions of the allopuriноls, or in the patients who are treated with the alloprinol within 3 months. And so after that, the patient no need to come back to test the HLA-B5801. So however, in my experience, I think that in the patients who are going to treated with a higher dose, or who has the renal status impairment, like creatinine kinase, creatinine levels increasing, for example, they should be screening for that patients, even they are treated longer than 3 months.
All right. I think that's the end of the questions list.
So let me talk something that so in some setting that if you cannot access to the pharmacogenetic testing before prescriptions of the drugs, such drugs. So if you can, in my practices, so I would recommend to do the prescriptions with no lag times. And so in my labs, we try to return the result within 3 days. As we know that the SCAR is a delayed hypersensitivity. So if the patient got prescriptions of the drugs, and we will monitor and we will close monitoring of the patients. So if the doctor can prescribe drugs with pharmacogenetic testing request, And if they are positive of the biomarker, we will call to the patients and come back to the hospital. And if they are negative, we will let them treated with the standard guidelines.
Okay. Thank you, everyone. It has been a highly educational and enriching sessions in the last 90 minutes. Please join me in thanking all three speakers tonight. I'll now hand over to Professor Purwankar.
Hello, Jason. Thank you very much. And I would like to express my sincere gratitude to all the three speakers. Were outstanding, I would say. Professor Lee, Professor Sukisen, and Professor Min Moon Tang. They're just brilliant. I think what you delivered today is something of the highest standards, and we are proud to have this coming from our JAFCA and also from the leadership too. I'm also grateful for Jason for organizing this and for leading this brilliantly. Thanks to all the audience who were present and actively sent in questions. We look forward to your continued engagement with Apache as we move forward together as an organization for the sake of our patients, for the sake of our specialty, and for a better life for everyone. And now I'd like to announce two things. One is upcoming next month. We have the Apache Allergy Week, which we have every year. And this year, the topic is on One Health, One Planet, climate mitigation, and digital health. This in fact, is the most important thing today. It's also part of what the G20 mission is also in life and environment as part of the agenda of India's G20 presidency. It's also the motto of WHO, and we look forward to all of you participating in this. We will have a live webinar on the 12th of May with global leaders and regional panelists. And then I would like to also invite you to Apache 2023, which is being organized of Apache together with the Clinical Allergy and Clinical Immunology Society of Singapore. It was 2010 that Apache had a congress there with over 2,000 delegates that time, organized by Professor Hyoki and Professor Biwa Lee. Today we have with us Professor Hui Kang and Bernard Tong, Grace Chan, and my Apache president, Professor Wang, and all of us from the Apache board, welcoming you to please come. It's going to be an outstandingly scientific treat and a culturally lovely time. So do join us for Apache 2023. And let's walk the talk and walk together. And you will have a chance also to do very interesting things like the asthma run. Oh, where's Jason? Can we get him also? Take a picture together? Okay, Jason, you be the center. Oh, was it fantastic? I have to tell you, just was outstanding.
Are the audience still there? I mean,
yeah, I literally say this is like as good as a plenary of a Congress. And you know, all of you are invited there for Apache 2023. You shall receive invitations. You're already in the program.
Thank you so much. Thank you so much.
Thank you.
Khop kun
See
ka.
you.
Khop kun ka. And thank you also, Min Moon. Thank you for being there. And thank you, Professor Lee, for organizing all this in such a short time. Brilliant lectures and a fantastic discussion. And thanks, Jason, for setting it up, please, and organizing everything. And of course, our secretariat for all the logistics and everything.
There's another question that we forgot to ask from Hong Kong. I think we should try to answer online.
Yeah. Any pending ones we should do online.
Okay.
Yeah. And just to let you know, Apache is just revamping its website. So all these will become even more user-friendly.
Okay. All right. Okay. Yeah.
Yes, but let's not wait for that. Let's do the answering. So maybe, Jason, you can reach out to who you want to for the pending questions.
Sure, I will do that.
Then collate that and give it to Shiranga and she will put it up.
Okay.
Okay.
Thank you.
So,
thanks, everyone.
Thank you so much.
Okay, thank you, everyone.
It was a pleasure meeting everyone tonight.
Let's stay in touch.
All right.
See you.
Bye-bye.
Bye.
Bye.